Hello, ma'am. In next 30 seconds, you can start. You can start now. Please start. Hello. Good afternoon. This is Dr. Girija Wagh, and today we discuss about the low-dose mifepristone in uterine fibroids. As we all know, that fibroids are a very common pathology that we as gynecologists experience. And many a times one wonders what can be done, because not always is it possible to do a surgical approach. And with the changing lifestyle currently, we can see that there is a huge rise in incidence of fibroids. And naturally the question comes, how do we tackle them? It's always better, even if it's a very common pathology that we encounter, it's always better to look at the proper risk factors that possibly the patient may be having as a background. Now, we all know that they are known as leiomyomas or myomas, which are actually monoclonal tumors of the uterine smooth muscle. And it is also believed that it probably artery walls, which are supplying the myometrium. And they're present with menorrhagia, pelvic masses, pelvic pain, infertility and obstetric complications, and various risk factors such as race, age, genetic factors, especially the Asian ethnicity. Asian African ethnicity is known to be predisposing. Early menarche parity is known to influences in the contrary. And factors such as obesity, hypertension, which are much on rise today because of the metabolic disorders or metabolic boom, and in absolute use or ingestion of caffeine and alcohol have been identified to be important modulating factors. Now, if you look at the prevalence in our country, nearly 20 to 30% of Indian women in reproductive age group have fibroid uteruses, and at any given time, nearly 15 to 25 million Indian women have fibroid uteruses. And if you look at the prevalence of age, is predominantly seen around 46 to 50 years of age, with matching ages just beyond and before. And the ones which really causes a lot of 36 to 40 and 41 to 45, because most of the times these women would present with abnormal uterine bleeding, causing a lot of concern, which requires to be addressed. Now, the FIGO has come up with a classification, and whenever we look at the abnormal uterine bleeding, now we have come to a consensus that it is always better to categorize the causes of AUB in the form of a mnemonic, the palm coin classification. And if you look at the palm coin classification, the L in the palm stands for leiomyoma, and submucous and other have sort of been attributed a separate identity, because we all know that submucous leiomyomas are definitely responsible for many symptoms like menorrhagia, dysmenorrhea sometimes, fertility issues, and therefore they require to be given attention. And sometimes we may be able to sort of differentiate whether we require to take a surgical approach or can we give them a medical therapy. All this would be sort of depend on the exact graphic, and that is something that we must definitely get when you are clinically evaluating this patient by getting a good ultrasound, and especially if the women are very obese, it's always better to get a good transvaginal sonography done. Now, menorrhagia, pelvic pain, dysmenorrhea, anemia, infertility, bladder and bowel pressure happens to be, and we are all well versed with the commonest presentations that are associated with fibroids, and they are known to influence fertility by interfering with the sperm or the ovum transport, enlargement and the deformity of the uterine cavity, distortion of the cervix, and the obstruction of the tubal ostia, depending on whether they are cornally placed, increasing the chances of miscarriages, especially submucous fibroids, or they may have, may be responsible for increased irritability of the uterus and increases the risk of obstetric complications like dystocia, PPH, and then puerperal sepsis can also be the cause. Now, if you look at the surgical therapies that we have, from myomectomy to hysterectomy, and various kinds of approaches, especially with the laparoscopic approach, we have been able to tackle this much effectively by minimal invasive surgery. But there definitely are certain disadvantages. Many a times patients choose to undertake uterine artery embolization, but I have had some experience with patients who have undergone a UAE in the past, and they have come back to us with the recurrence, and then maybe many times the ghost residue of these fibroids remains back, and sometimes eventually they require to be taken off. So if you look at their disadvantages, we all are aware that especially when we're talking of restoring the fertility or sort of conserving the fertility, usually the approach is by doing a myomectomy. While if fertility is not an issue and if the patient is really symptomatic, then sometimes, many a times, we feel that it's a benign condition, but we may have to take a recourse of hysterectomy. Really wonder, is it important? And that's how we have to look at certain conservative approaches. If you look at the various options, which are non-surgical options, are of course the uterine artery embolization that I spoke about just now, or they can be fibroid ablation, and it can be a focus ultrasound which can be used, and that also has been found not to be very easily accessible for patients, but also sometimes not very effective. Medical options such as the combined oral pills, the progesterones, where oral or IUCDs. Now, IUDs definitely cannot be used, LNG IUS cannot be used if the uterine cavity is very badly distorted. NSAIDs are symptomatic, and during that period of time can give some respite, tranexamic acid and others. And then, of course, we have also sometimes used the GnRH analogs, and these are usually used preceding to a surgery, wherein we can sort of reduce the size of the fibroid and make it amenable for a laparoscopic approach, just to find out. And of course, options like hysteroscopic myomectomy, especially targeted towards submucous fibroids. Now, the limitations of medical therapy, of course, are especially when we use the progesterogenic agents like the oral progesterones or norethistérone. There is a possibility of a weight gain, acne, breakthrough bleeding, and increased size of myoma. Injectable progesterones like medroxyprogesterone acetate or DEMPA, which we are using also as a contraceptive, can also cause similar problems with bloating and a theoretical possibility of a loss of bone mineral density. And combined oral contraceptive pills, sometimes we may feel that the dose may not be optimal, and there is a possibility of a breakthrough bleeding, and may not be safe for long-term use or can increase the size of the myoma. Now, the future of medical therapy definitely exists. Traditionally, the dominant thought was that fibroid growth was fueled by estrogen, and thus estrogen-reducing agents such as the GnRH would reduce the fibroid volume and induce amenorrhea. And it has been now discovered that it is not only the estrogen receptors, but there are progesterone receptors which are also required for the cellular proliferation and fibroid growth. And fibroids are known to express elevated levels of both types of progesterone receptors, the PRAs and the PRB. And progesterone and its receptors therefore represent potential targets of inhibited uterine fibroid growth. Now, functional role of estrogen and progesterone, if you look at, fibroids are known to overexpress the estrogen and the progesterone receptors, And this is something that is very difficult to find out many times in our patients. But there have been now a huge evidences which are saying that progesterone plays a vital role in promoting uterine fibroid growth. Progesterone receptor binding is 3 times higher in fibroid as in myometrium, and estrogen receptor expression on the uterine cells is inhibited by the PR pathway. So with this particular background of understanding based on evidence, we naturally want to study what is the effect of progesterone on fibroids. It seems to be having a dual action on the fibroid growth. It stimulates the growth by upregulating the BCL2 and the EGF factors and downregulation of the TNF-alpha expression. Progesterone is also believed to be a physiological regulator of uterine fibroid growth by increasing the EGF expression and increasing the angiogenesis. And on the other hand, it is known to inhibit apoptosis and also increase the fibroid cell proliferation. So what does this tell us? That progesterone definitely is contributing phenomenally towards the growth of the fibroids. So it has stimulated, therefore, interest in modulating the progesterone pathway. Naturally, can we consider this? Can we do something about the progesterone action modulation? And we all know that SPRMs, the selective progesterone receptor modulators, have been in practice for quite some time, starting off with Saheli, which was very popularly used as a contraceptive, to the ornodexaphene, which we are using as a method of management for various other things. And now this new SPRM in the form of mifepristone, which we are very commonly using as an abortifacient, but this actually is the first SPRM, and it has a very strong antiprogesterogenic action. And it is also found that mifepristone for uterine fibroids has been studied. It's not something that we have just come up with. There have been trials, there have been studies which have been done. And out of more than 35 clinical trials, about 24 Indian controlled trials have been there, published, and it can be compared with GnRH agonist in terms of efficiency. Now, the dose which is available is 10 milligrams to 25 milligrams, and these are clinically evaluated strengths in the Indian ICTs. I know about 6-7 years back when I wrote the one of the chapters on fibroid uterus, that time we were just saying that yes, it has to be available, but now we are seeing that of late it is easily available in the Indian market. And in studies, it decreased the fibroid size considerably, decreased menorrhagia, dysmenorrhea, pelvic pain, and the urinary symptoms. Now, what is the mechanism of action of mifepristone, and how can we compare it with the GnRH agonist? Now, we all know that GnRH would act through the pituitary. There's a direct action on the pituitary, inducing downregulation and desensitization of the GnRH receptor, producing a hypogonadotropic state with consequent reduction in estradiol and progesterone. While SPRM would have a selective action. And how? In fibroids, there will be a direct action on the fibroids, reducing their size through the inhibition of cell proliferation and induction of apoptosis. Apoptosis is cell damage. And endometrium, it will cause uterine bleeding would be stopped, results in benign and reversible changes in the endometrial tissue, which are called as progesterone receptor modulator associated endometrial changes, the typical PAECs, which many workers have studied. And through the pituitary, it also has an action from there, inducing amenorrhea by inhibiting ovulation and maintaining mid-follicular phase levels of estradiol, which is very important, and that's how probably it helps in trying to conserve the bone density. Now, if you look at the various Indian clinical trials, and these have been presented in various conferences, the AICOG 2016 conclusion was it is effectively known to relieve fibroid symptoms and decrease the size, thereby avoiding unnecessary surgery, especially in perimenopausal women. The ASRM 2009 concluded that low-dose mifepristone had a shrinkage effect on the fibroids, which was maintained for as long as the medication was used. And in 2013, low-dose mifepristone is efficacious in reducing leiomyoma, volume and leiomyoma-related symptoms of menorrhagia and dysmenorrhea. Now, low-dose aspirin treatment for abnormal uterine bleeding was studied by Alka Kripalani Madam and her group. And it was found that intramural or subserosal myomas from grade 2 to 6, tranexamic acid or COCs or NSAIDs, LNGOIs, if treatment fails, myomectomy depending on location. And if we find if the women are more than 40 years of age, fertility is not desired for small fibroids, medical management followed by hysterectomy is what is planned. Short-term treatment, GnRH agonist with add-back therapy followed by myomectomy. Long-term management by LNG-IUS and newer medical options such as ulipristal acetate or low-dose mifepristone could be considered. And that time this was not available in India. But today we know that we have an access to this mifepristone for us, and we have these people from this particular community who have got it for us, made it available. That is the Acumentis. Now, there have been various meta-analyses on low-dose mifepristone on uterine fibroids, and there have been Cochrane studies and various publications, and it has been also endorsed by the ACOG and the ASRM in its own journals. Now, Cochrane in 2017 concluded short-term use of SPRMs resulted in improved quality of life, reduced menstrual bleeding, and higher rates of amenorrhea than were seen in the placebo, and SPRMs may provide effective treatment for women with symptomatic fibroids and are associated with endometrial changes which are benign and are not related to cancer and are not precancerous. In 2012, the Cochrane had concluded that the mifepristone reduced heavy menstrual bleeding and improved the fibroid-specific quality of life. There's been a systematic review of mifepristone for the treatment of uterine leiomyoma with an objective to systematically review the effect of mifepristone on uterine leiomyomas, size and symptoms, and 6 studies involving 166 women with symptomatic uterine leiomyoma were included, and the subjects received from 5 to 50 milligrams per day of mifepristone for a period of 3 to 6 months. And it was observed that there was reduction in the uterine volume by 27 to 49%, in the leiomyoma volume by 26 to 74%, and it reduced the prevalence and the severity of dysmenorrhea, menorrhagia, and pelvic pressure, and rates of amenorrhea range from 63 to 100%. So the published trials of mifepristone showed, therefore, definite reduction in the size and the symptomatology associated with the leiomyomas. Now, we also have definite Indian clinical evidence, and this has been the group of Professor Manjula Srivastava, who have studied 100 symptomatic uterine fibroids, and dose decided was 10 milligrams of mifepristone for one group and 25 milligrams of mifepristone for the B group. The age was between 35 to 48 years, and complete amenorrhea was observed in women who took 25 milligrams, and scanty and infrequent periods in 10 milligram groups were observed. And there was definitely relief from the pressure symptoms in the higher dose group by 98% and by 72%, and quite a considerable number in the lower dose group. Patients were given mifepristone as a name of fibroids of 10 milligram and 25 milligrams, and then they were studied after 3 months and 6 months, and they were found to be very effective in alleviating the symptoms and the size of these fibroids. Now, 3 clinical trials with mifepristone versus GnRH agonists have been studied, and the GnRH agonist studied here was the leuprolide acetate, and it was found to be as effective, mifepristone compared well with the GnRH agonist, and is better tolerated than the GnRH agonist with fewer side effects. There's a lesser recurrence rate with mifepristone compared to GnRH agonist group, and mifepristone is more effective in decreasing the blood flow to uterus than the GnRH agonist. Now, the efficacy of mifepristone versus GnRH analog was studied in 2019, and this particular publication from our own country in Ernakulam divided the groups into 2, with mifepristone 25 milligram once a day for 3 months in group A, and in group 2, patients were treated with injection leuprolide acetate depot 3.75 milligrams intramuscularly once a month for 3 months. And there was a marked relief with significant decrease in visual analog scale score in both the groups, and thus it was found that 25 milligrams of mifepristone daily compared well with the GnRH agonist leuprolide. Now, it was also found in the study of these 50 patients where the size of the uterus was studied in Orissa, And the volume of the fibroids was measured before and after the treatment. There was definitely a specific and um, thing. Now, additionally, we find that the leiomyomas with mifepristone and its outcome in South Indian population was studied by this group. Again, 45 symptomatic fibroids, and especially the age group was also 24 to 45 years. And we are also definitely are worried about those young women or young girls who are coming to us with fibroids, and how can one help them, because it's always better not to take a surgical recourse. And therefore, we look at mifepristone as a very promising treatment. There were no major side effects observed during the course of the study, and the drug was well tolerated before and after the treatment in this particular publication, because that is one concern that we have. And low-dose mifepristone in the medical management of uterine leiomyoma was studied in this North Indian tertiary care center under the group of Professor Alka Krupalani, and it concluded that there was reduction in the myoma in the uterine volume, and pain using the Wagh score, and reduction in blood loss using PBAC and endometrial biopsy was observed. Now, there was also a significant reduction in the mean PBAC score in both the groups, and it was found that 25 milligrams was a little more effective for a shorter duration than the 10 milligram dose group. And there was a marked relief with significant decrease in the pain score, and most importantly, there was elevation of the hemoglobin level, and therefore, because it conserves or it reduces the blood loss. There was no significant change in the estradiol levels in both the groups, and repeat endometrial histopathology did not reveal any complex hyperplasia or atypia in either of the groups. And therefore, the study concluded that mifepristone caused symptomatic relief with more than 90% reduction in the menstrual blood loss, greater myoma size reduced occurring with 25 milligram dose, amenorrhea in 90 to 95% patients, which was reversible, and mifepristone can be a reasonable choice for management of uterine leiomyomas, as it is administered orally, is cost effective, and has very mild side effects. It can be a reasonable choice, especially in perimenopausal women in whom myomas could regress after menopause, and unmarried patients who want to avoid surgery naturally. Now, the role of low-dose mifepristone was also studied in Haryana, and here they found that there was a decreased uterine and fibroid volume measured by transvaginal sonography, and there was definitely a reduction in the menstrual and the pressure symptoms. And the study concluded that low-dose mifepristone had a shrinkage effect on the fibroids, which was maintained for as long as the medication was used, and it did allow time to correct anemia and plan surgery. So they're given pre-operatively. Now, low-dose mifepristone in treatment of uterine leiomyoma, a randomized double-blind placebo-controlled clinical trial was conducted to evaluate the effect of low-dose mifepristone on leiomyoma-related symptoms. And in this 40 women study, it was found, and it was compared, 10 milligrams was compared with the placebo, and it was found that there was definitely a good outcome. And you can see here that there was complete relief of dysmenorrhea, which occurred in 80% of women, and mean hemoglobin increased from 9.5 to 11.2 gram per deciliter. And there was cessation of menstruation, dysmenorrhea, and pelvic pain, which was very, very remarkable. And there was also a significant reduction in the uterine leiomyoma and the size, and thus 10 milligram mifepristone for 3 months is found to be effective in reducing menstrual blood loss, increasing the hemoglobin, and reducing uterine leiomyoma and the volume. Now, 30 women of the reproductive age with uterine fibroids between 4 to 6 and fibroids less than 3 centimeters were studied, and both doses equally effective for menorrhagia and fibroid shrinkage were observed. There was reduction in pain, slightly more pronounced in 25 milligram group, and those who did not respond to 10 milligram were shifted to 25 milligram, resulting in reduced myoma size and a sustained effect. There have been case reports published in the AICOG 2020, and it was found that especially in women who were having a surgical risk for ischemic heart disease or moderate aortic stenosis, mitral stenosis, etc., were found to have a considerable reduction from 592 cc to 299 cc in this particular 48-year-old woman who had a hemoglobin of 5.3, and this definitely helped her to be free of symptoms without any surgical intervention. So, in conclusion, patients who are high risk or unwilling for surgery, mifepristone can be considered as a safe alternative, or it can also be considered as a good alternative before you decide to undertake a surgery in that particular patient. There have been international clinical trial summaries and various fertility study journals, and the AMJ journals have published a similar kind of data that we just now discussed, wherein there was an effective use of an effect of mifepristone on uterine fibroids. In a dose of 150 milligrams per day, it was found to be safe and well tolerated in these patients, and there was no atypical hypoplasia noted with mifepristone. Endometrial biopsy showed no pre-malignant changes with 50 milligrams per day of mifepristone for 3 months, and there was no risk on the bone mineral density or the osteoporosis, and there was no change in the liver enzyme elevation either. And it was also found to be effective as GnRH analog without any osteoporotic or osteomyelitic effect, lesser side effects, good compliance because orally taken, plus pocket friendly, allows time to correct anemia and plan surgery. Menses revert after stopping the therapy from any time between 34 to 85 days, and lesser recurrence than GnRH analog, because we many times observe that once you've taken the GnRH analog, there can be a sort of again a regrowth of the fibroids back to its normal size, which doesn't happen with mifepristone, and it is known to improve the health-related quality of life. So the dosage which is recommended is once daily after meals, should be started on day 1st to the 7th of the menstrual cycle for better results, and should be taken on the same time every day. Minimum treatment duration should be 3 to 6 months. So this is what we have to bring to you as far as the information of this very new promising product is concerned. I have been using this particular molecule for the past 2.5 years, and I found it to be extremely promising because sometimes we have women who are obese, who are having various kinds of cardiovascular risk, are diabetic, and we found that it is much easier in these women, especially to use these fibroids, these therapy. There are some questions which I can see here is, Dr. Mayuresh wants to know, I would like to know if mifepristone can be used in adenomyosis, and the answer to this is yes, because the same kind of receptors have been studied even in the adenomyotic pathology, and there are small powered studies which have showed, and there is a histopathological basis wherein it has been found to be effective in adenomyosis. And somebody has asked me that we have to suppress the progesterone. I'm sorry, Dr. Gore, I did not get this question. If you could elaborate this further. Dr. Krishna wants to know if there are any guidelines that recommend low-dose mifepristone for uterine fibroids. Yes, there are guidelines which are available, and you can see that Dr. Kriplani Madam has also spoken of it, and maybe I can speak to our friends here from Acumentis, and we can share this with you definitely. Santoshi wants to know, for large fibroids, should we do surgery for medical management? Santoshi, I would recommend that it's always better to give her a mifepristone, because that will give us an opportunity of reducing the size of the fibroids, improving the patient's, the hematocrit. And many a times we will find that they may be either surgically amenable, or maybe they would be completely symptomatic relieved and surgery may not be necessary. Dr. Gagan wants to know, is this therapy useful for all types of fibroids? Definitely, it has been found to be very effective in 90% of the fibroids, but 10% sometimes, we do not know. There can be a preponderance of an estrogen receptor modulation there. And sometimes you may have diagnosed it as a fibroid. It may be an adenomyoma, and some adenomyomas we know are extremely, very, very resistant to some treatments. And therefore, this requires to be definitely investigated. Dr. Arpana wants to know how long it can be given to patients once started. For 3 to 6 months, Arpana, you can give. There have been experiences where when the fibroids were stopped, then the treatment was stopped. There was over a period of time, after 3 months or so, there was sometimes occurrence or recurrence of the symptoms again. So what we have tried in some patients is we start off with a 25 milligram dose for the first 2 months, and then go on to the 10 milligram, which can be continued for the next 4 months. And in some patients, that has been found to be extremely useful. Kulvinder Kaur wants to know, does it only shrink the size or cures? Fibroids cannot be cured, but they are definitely reduced in size. And sometimes there can be a reversal. Like in few case studies, they found that submucosal protruding fibroids have turned into intramural fibroids, and like they have receding the exposing part into the cavity, giving rise to less symptoms of abnormal uterine bleeding, pain, and so forth. So they would not completely disappear, but they will definitely reduce in size. And Dr. Arpana also wants to know, can be given more than 3 months if required? Of course, you can give for 3 months. You can. There have been few patients in whom we have even given this particular treatment for over a period of about 1 to 2 years without any other side effects. And now Dr. Ayush Gore has asked her whether it can be given OD. Now, some studies, when they've given 25 milligrams, they have studied 25 milligrams OD, while what I have very commonly used in my practice is 10 milligrams twice daily. So any of these two can be considered. Of course, we have to first get into more and more experience and extrapolation of our data to be able to be more confident about using this drug. Dr. Tooley has thanked me, and he thank you for logging in with us here this afternoon, and thank you for appreciating. Dr. Avni also wants to thank me. Dr. Prashant says, any chance of endometrial hyperplasia with the therapy? No. Whatever studies have been studied, and Dr. Alka Kruplani's group and also an Australian study has shown, they've gone ahead and studied the endometrial samples, done a histopathology, and there has been no such occurrence of hyperplasia that has been seen. And the PAEC, which we see, is not pre-malignant, not a precancerous condition. Now, Dr. Bhanumati wants to know, are there any major disadvantages or side effects? No, none, no major disadvantages or side effects definitely have been observed up till now. Sometimes some patients experience a little kind of perimenopausal kind symptoms, but I don't know whether there can be an anxiety disorder or what, or maybe they may be having it prevalent. But some patients also experience a little amount of bloating, like water retention. Now, this goes actually controversial in the sense that if it's going to be a progesterone antagonist, why would it cause these kind of symptoms? It's a question that we have to answer with more and more experience to be gathered. But I think I have answered your question. We can give it maximally, and we need to have more and more experience to identify. And more usually, patients have respite within a time period of 6 months, and therefore we many times did not continue the therapy after that. But as I told you, with some few patients, I have continued it longer. Annapurna wants to know is there a rebound increase in size is noted after stoppage of therapy? There have been few colleagues, because I've spoken about this in some parts of our country, and there have been few colleagues who have experienced this very rare occurrence in few patients. This can happen. In these patients, you can step up the dose or maybe continue dose for a longer period of time. Dr. Archie wants to know, is mifepristone a short course, that is 3 months treatment? How long would the effect of treatment last? It's usually observed to last for a period of 3 to 6 months, and many times by that time, the patient's other issues may have come over. She may have attained menopause, hit menopause, or maybe she's become pregnant, and therefore these things can be taken. I have used this very effectively in some patients who are trying to get pregnant also, and this has helped. Also, some patients in whom we have done adenomyoma resection, I have also used in 1 or 2 patients of mine. After that, given them mifepristone, by the time they are recovering, and there has been one spontaneous conception. Now, these are very, very small anecdote cases, but this has been an experience. Dr. Priya wants to thank me, and Dr. Kajal says that she was happy with the explanation. And thank you, Kajal. You are always welcome. Dr. Andes Sivam says, thanks for the valuable information. Thank you. Welcome for that. Dr. Shushmita was happy. Deepshika said, should we monitor any blood test? Actually, there is no need of monitoring any blood test, but since the patient has fibroid uterus, please go back to the risk factors. If she's obese, if she's hyper, if she has iron deficiency, has low serum ferritins, or if she has other micronutrient deficiencies, analyze them and correct them, because we all know that these are contributory factors for fibroid pathology, and these require to be corrected to give patient an effective treatment. So there has to be a holistic approach. We cannot just keep on concentrating only on the therapy part. We also have to look at what many times taking good micronutrients, having a good lifestyle has known to reduce the occurrence of fibroids, and this has to be used as a supportive therapy. Afsana wants to thank me. Thank you so much. You're welcome. And so does Dr. Ilamati. Dr. Aryan Tiwari also is very happy and he has said thank you. Dr. Kavita, thank you so much. You're all welcome for logging in here. And Sunshine, I think that's a wonderful name to have, doctor, wants to know what is the best guideline to follow for Indian population. I would always suggest that any situation that you have is first and foremost do risk assessment. Do not ignore any of these risk factors. Is she having a high body mass index? Is she having any other comorbidities? Is she anemic? What is the complaint of the patient and what is the purpose of the therapy? Because her fertility aspects, her so many other, her timelines in her reproductive age, all have to be taken into consideration. And therefore, we have to also keep on looking at the good clinical practice recommendations, which sometimes the FOXI comes up with. It revises them every 5 years, and this can be considered. And of course, you can feel free any time to talk to me and ask me if you have any questions, which I can explain with whatever access of knowledge if I have. Bapi wants to thank me, and I have been asked a question: can it be given in patients of endometrial hyperplasia without ATPM? This is something that requires to be investigated. But looking at the HPV experience, it can be considered as a therapy, of course. Dr. Sashank says that is the plane of separation affected? No. And that is one of the most wonderful experiences seen with mifepristone. And this was with my own cousin that I experienced. Had a massive fibroid. It was an extremely massive fibroid, making her uterus to the size of 24 weeks. And that time, mifepristone in the requisite dose was not available. So whatever mifepristone was available, I broke it into 4, that small little thing, and gave it daily for about a period of about 10 days. And we found maybe I must have given her 25 milligrams or 50. And there was definitely reduction in the size of a fibroid, and we took her for laparoscopy. She has already become pregnant. She has had her children now, and everything went fine. So, and we found that there was no distortion in the plane of surgery. Thank you, madam, for sharing great information, was what Dr. Jyoti Kumari and Dr. Bhanumati wants to say. And another question asked is it effective if patient takes OD into 1 month instead of during menstrual period? Actually can be considered, yes, because we can give it definitely, because we can start it from the 7th day. It's always better that you start it on the 5th or the 6th day at least of the menstrual cycle. And Dr. Rohit, Dr. Anju want to thank me. Dr. Afsana wants to know recurrence can repeat the same treatment. Yes, you can start with a little higher dose and then taper to the lower dose. Is it advisable to do endometrial sampling for pre-treatment or post-treatment? Actually, it's not necessary, but all the same, whenever we start therapies, it's always better to do any kind of a transvaginal scan. Because it may not be a fibroid uterus, it can be an endometrial polyp. And you must do a good TVS assessment before you embark on any kind of therapy in any patient. So therefore, and with good resolution ultrasounds, we are now able to identify a lot of things there. Will the size of myoma decide the dose, madam? Actually, we can't say that. And because we do not know whether the size extrapolates with the receptors of the progesterone. Because fibroids also have a component of a fibroid tissue. So we do not really know where would be the receptors more active, whether that is in the fibrogenic tissue or the myomic, the muscle component of the fibroid. And therefore, this is something which will require to be titrated and then clinically assessed. Then, what is the fertility rate in nullipara with multiple fibroids treated with fibro-ease? Now, this requires to be studied further. And I'm sorry I do not have an access to this information, Dr. Nair Quadri, but we will definitely look into this. It's useful for 3 months. On long time, it's useless. Okay, that's what is your experience. Then maybe we may have to try it in more and more patients. Should the patients practice contraception during the treatment? It is better, especially at the start of the treatment. In the first 6 weeks of the treatment, it is better that the patient uses a barrier contraceptive. After that, she can be off the contraceptive usage. And there are many others who have thanked me for the explanation. Thank you so much. No contraindications as yet. And in perimenopausal women, Dr. Druma, we can consider giving it from 3 to 6 months to even a period of 1 year and avoiding surgery. I think we'll be doing a great deed by conserving uterus and not using it unnecessarily. Somebody asked me for a guideline, and I must mention that we have mentioned this particular thing in the guideline which we submitted to the state government of Maharashtra. It is on the Maharashtra state government, online portal, which is talking of saving uteruses. How to avoid a hysterectomy or alternative treatments in situations where you can use them as an alternative to hysterectomy, and there you can find an evidence where we have mentioned about mifepristone. Uh, so I think can I speak to Santoshi? Are there any more questions? Whether to take continuously or during the first 10 days of menstruation, which is continuously can be taken for 3 months, or you can even take it maybe for a period of about 29 days. But in all my patients, I've always given it continuously for 3 to 6 months. If the patient conceives during treatment, can you continue the pregnancy? Absolutely, you can continue the pregnancy, because you must be aware that even when we give the abortion pills to the patient, and then there is that particular syndrome where there are multiple abnormalities in the baby, is not attributed to mifepristone at all. These abnormalities are because of the misoprostol that we are giving. Because it has been studied that misoprostol, which is given as an abortion pill, is known to cause the uterine artery constriction, which causes a loss of blood supply to the embryonic plate. And that is the reason why we would have that typical syndrome which is seen in which an abortion pill has been given. And it is not because of mifepristone, but it is because of misoprostol component of this abortion pill. And someone here has requested to give us a seminar on PCOD also sometime. Certainly, Dr. Ayush Gore, I will definitely make an attempt to do this. Please be in connect with me. I know you have my contact numbers, I hope, and you can tell me and I'll log you onto a PCOD kind of a thing which we need to talk. Can we use it in endometrial polyp? The answer to this is probably no. Maybe till the time you're bleeding, you're building up her blood, till you're correcting her anemia, you may consider using this because this is something which requires to be studied. But it could be effective, looking at its mechanism of action. Yes, it could be effective. Again, with an endometrial polyp, I just have an anecdotal experience with one patient who was trying to conceive, had anemia. So I just told her that let's take mifepristone. You have an endometrial polyp. I do not know the evidence, but then this is supposed to be the safest drug that you can take. And while she was building up her anemia, at the end of 3 months, she conceived. Endometrial polyp was still there in the corner, and the pregnancy went on. So endometrial polyp may not always be a deterrent to a pregnancy, because sometimes it can be just a fleshy polyp. Now, whether it has a better effect on fibroid polyps or whether it acts better on the intramural fibroids, there have been a few studies in which even it has been found to be effective on submucous fibroids, intramural as well. Yeah. So, Santoshi, can you hear me?
Yes, ma'am. I'm online. There are more questions, as in the questions are not coming up. There's one question, I think this can be the last question which we can take up from Dr. Afsana.
Yeah, there is any incidence of drug interactions if patient is diabetic, hypertensive, heart disease, or has thyroid? No. No drug interactions have been observed. And in fact, it has been found to be safe, especially in these patients. And these are the ones who are going to be risk for any other hormones, or they are going to be at risk for any surgical interventions. And here, this definitely is of use. And especially, I think, with the COVID-19 pandemic that we have around, where we want to avoid any kind of a surgery with the patient, or we want to help them, maybe we're giving them online treatments. I think this is a very nice modality of treatment which you can give them online prescriptions where they can take it and at least be, sort of safe during this time. If the patient conceives during treatment, should the treatment be stopped? Yes, it is better to stop the mifepristone and let the pregnancy continue. Should additional restrictions be placed upon the use of mifepristone? I don't think so, that there would be any additional restrictions here. And I think that's it.
Yeah. Rest of the questions, I guess it can be sent to Madam's mail ID.
Yes, absolutely. Because I can see a few people still typing something there.
Yeah.
And have we recorded this, Santoshi?
It was already, yeah, it was
Yeah, ma'am.
recorded.
Khushbu here. We have recorded it and we'll send you the record and the report as well. And the questions
Okay.
also, if there are more, we'll mail you, ma'am, for sure.
Okay. Yeah.
So thank you, madam. My name is Shubhajit. I head this division. On behalf of Acumenters, I thank you for delivering
Thank you
this
so much.
wonderful. Thank you. Thank you very much. And a lot of doctors have logged in. I can see on my laptop. And the best
Yeah.
thing that a lot of questions are being asked, madam, that which is of course pertaining to my area regarding the availability. Let me tell you that it is available across the country with all major chemists and all major online pharmacies. And
Correct.
every day I must be getting 2 to 3 calls from various online pharmacies, from MedPlus to OneLine, all those things that we need the drug basically. So what, since this is a drug that has to be used for 3 months or beyond, we are ensuring that this drug is sent to all the major locations by flight, because the government of India has arranged special flights to be flown in with the important medications. So Fibroids has been accepted and we have sent it across to all the major cities. So the availability of Fibroids even in this COVID times is not an issue at all. So that's a
Okay.
good thing that we have done basically.
Very nice. Thank you so much, because I felt that
Thank
especially
you.
in the COVID context, this medication is really going to be of use to us, So we can
Absolutely.
safely prescribe it to the
No, no,
patient.
no. It is available, and the way I am getting phone calls from online pharmacies, it is very heartening to know that means many doctors are using it, and
Yeah.
many doctors are asking that our patients, we have given it for 3 months now, they have medicines for 2 months. One doctor has asked, patient has telephoned me, I have taken for 2 months. What about the third month? Will I get?
Yeah.
Stocks have been dispatched, and I don't think you will have any problem of getting it.
Hmm.
However, still, if you get it, you get in touch with our pharma sales people, whoever is meeting you,
Correct.
and we'll ensure that you get that. That's for sure, basically.
Thank you so much for that, because it's
Thank
so
you.
important.
Yeah, yeah. Thank you, ma'am, and thank you once again, all doctors, for logging in. Thank you very much.
Thank you.
Thank you.
Thanks.
Thank you. Thank you.